Meanwhile, provinces across South Africa established field hospitals to cope with the surge of COVID-19 patients. But as cases drop, some hospitals are being dismantled. Should the government continue with this approach and redirect those services to other pressing health needs, or should they retain them in preparation for a second wave? Chair of Social Security System Administration and Management Studies at the Wits School of Governance, Professor Alex van der Heever, joins us now to talk about this. Prof, good evening and thank you very much for your time tonight. As I mentioned, the field hospitals were established to cope with the surge in a number of patients that our hospitals, particularly the public health system, would see in the time of the pandemic. Did they help ease the burden?
I think that the field hospitals were a contingency intervention in case the surge in the epidemic resulted in a huge number of inpatients, and particularly critical care patients, that couldn't be managed by the existing public and private systems. We have not seen the levels reach that point where we actually lose our ability to service patients with our existing services. So I think that the idea to go with field hospitals was very much an early decision based on essentially the Wuhan type interventions, and then a number of other countries which followed suit. I think that ultimately the health services have found they could probably manage the epidemic better, even with the surge in patients, if they didn't use field hospitals. But it also looks as though we are not going to need them going forward. And it's unlikely that we will see a sort of a surge in cases equivalent to the period that we've just been through, or another level like equivalent to that.
Alan Winde, Premier of the Western Cape, saying, well, they were certainly effective in treating sick patients, particularly the notable difference in acute care capacity. You share that sentiment?
Yeah, I think that they were helpful, and they were certainly. I mean, I think the Western Cape was extremely concerned at a point because they had reached peak capacity in the public system. So they were moving patients into their field hospital. They had fitted out their that hospital with oxygen, and they were able to staff them, and that helped treat certain of the patients in sort of the equivalent of a general ward bed without having to refer them into high care or ICU. So I think that it helped relieve the pressure, and it wasn't necessarily an improper move. But I think that what they would prefer to do is to now manage the situation with their existing services. I don't think that they feel they need it anymore. They're not going to experience this kind of patient demand specifically for COVID. But it wasn't an improper idea to have or to pursue it at the time.
But it's your view, Prof, in one of the reports that this downturn in infection came as a surprise, right? Can we expect then that there could be more surprises, and maybe the second wave could be worse than the first wave, and therefore is there a need to dismantle them right now when there are still fears of multiple surges?
Well, I haven't yet seen somebody describe what they think would be behind a so-called second wave. I mean, we're likely to see a sort of ebb and flow in the epidemic. We're unlikely to see the virus eliminated until we get a vaccine. But it doesn't mean that the infection levels will rise to the levels that they have been in the past, but they will probably rise and drop for various reasons, but not necessarily for the same reasons that we've experienced now. So we've had a lot of the infections go through very populous areas and reach thresholds and turn down, possibly for a combination of reasons, including the health prevention interventions that have been introduced, as well as a degree of immunity that might have developed within those communities. But we don't have a complete picture of why the epidemic turned down, but it's possible that the reduced susceptible population in those areas caused a negative trajectory. But there are a lot of other regions and areas where there's still a sort of fairly large susceptible population, but not as concentrated. So we may see the epidemic still moving through those areas, but not necessarily rise to the same levels. So I think it's still a complex issue. And I certainly wouldn't be looking at any models to project what's going to happen. I think it's much more an issue of how we manage it and which areas are still.
All right. And Prof, in terms of messaging, are we sending the right kind of message when we are saying we're decommissioning field hospitals, and as you're saying it, they feel that they are no longer necessary? Does that, in a sense, send a wrong message to the general public and community to say, oh, well, the worst is behind us, and therefore we are seeing the kind of drop in adherence that we are, on personal witnessing it and driving around in the township, people just literally not wearing their masks, not social distancing, continuing with their lives as normal?
So the messaging definitely has to remain. I don't think that the winding down of the field hospitals is part of the messaging. I think the messaging on prevention and risk still has to be very consistent. I don't think that I've noticed that there is a tendency for government to almost talk down to the population, to say, if you're naughty, you're going to get infected and we will reintroduce lockdowns, etc. That, I think, is a very poor way of addressing the messaging at this point. I think there's been a loss of trust. And as a consequence, even when the right approaches are put forward, they are not adhered to. So I think that the important thing is to put everybody in the position where they understand exactly what's going on. And that what is going on now is that the virus is far from gone. If you haven't been infected, you are still at risk. And you still, when you go out into the open, have to treat everybody that you meet that you don't know as potentially infected. And if you don't, then you're at risk of a serious disease. So I think that messaging still has to go out. But it doesn't mean that we're going to see the epidemic rise in this way, but we are not going to see it go away. And over a long period of time, a lot more people will be infected, but not necessarily the sort of the concentration of infections so high. But an important feature of prevention is making sure that all those contexts and environments that are at risk of super spreading are better managed. Yeah. So I think that those are still going to remain a very important focus of both regulation as well as personal prevention.
There are some who are feeling that it is a good thing to decommission the field hospital and direct the funds to, of course, refurbishing the existing health facilities and putting in place oxygen reticulation. What does that mean?
Well, I think that so a lot of our existing health services are fairly good. We've also got many hospitals with closed wards, closed beds. So it does make sense to invest in our long-term infrastructure going forward. It also is appropriate to invest in appropriate and cost-effective prevention during this period. So right now, maintaining an expensive treatment facility when we need to prevent appears to be a poor use of money. But also, it does make sense to ensure that our long-term assets, healthcare assets, are properly maintained. So I think there is a smart restructuring of the spending going on, and I think they were, in the case of Western Cape, they were the first to basically begin implementing the field hospitals. They're the first to dismantle them, and they've basically been through the process of understanding whether this is a good medium-term measure. So I think its time has come.
Before we let you go, Prof, let's talk about that long-term prevention strategy that is cost-effective. There is a suggestion of a better detecting of new clusters and therefore focus there and focus also on antibody testing as well as the monitoring of hotspots. Would you share that sentiment?
Well, I think that the targeting of hotspots and sort of cluster-based outbreaks and managing them in various ways is going to remain a very important kind of strategy going forward. There is the question of the role of testing and tracing in the period going forward is going to be very important. If you look at countries like South Korea or New Zealand, they adopted an approach of disease elimination through their interventions. Now, South Africa we've had community-based infections. It's effectively become endemic within South Africa, and therefore we're probably not going to be able to eliminate the disease through testing and tracing, the conventional method. So the question is, what is the strategic role of testing and tracing? That's got to be decided on. It's probably not at the scale and the level that South Korea, and with the emphasis of South Korea. But we also need to be able to manage areas, but we can't lock down whole regions. We will have to identify those through the cases that come forward and prioritize them. I think in terms of any other strategy, I mean, essentially it's surveillance and intervention on a targeted basis continuously. And if we're finding that certain areas remain vulnerable to severe outbreaks, there has to be a focus on prevention in those contexts. It's not necessarily always a lockdown. It means that there's some problem there that's causing it. If it's a series of restaurants that are open, if it's people that are partying, if it's funerals, if it's those, you will identify them and you will close those down. Close those down, you will reduce the overall prevalence of the disease. So I think it's going to just be a continuous process of surveillance and intervention going forward.